All right. Good evening, everyone, and welcome to this evening's webinar. My name is Dr. John Afam Osemene. I'm the training representative of the Nigerian Society of Anesthetists, and this is our 12th resident webinar in this series. This webinar series is powered by the Educational Committee of the Nigerian Society of Anesthetists, whose chairman is Dr. Quinette Kalu, the president-elect of the NSA, and we are grateful to her and the president of the NSA, Prof. Dati, for providing this platform for our continuous learning and growth. Without further ado, I would introduce the moderator for today, a senior registrar in the Department of Anesthesia in the University of Nigeria Teaching Hospital, Enugu State, Dr. Eunice Amaka Ezinwa Bachili. Welcome, how are you doing?
I'm fine, sir. Good evening, Dr. John.
Good
evening, everyone. Thank you very much. So, good evening, everyone. Good evening, my consultants, chiefs, everyone here present. So, we're about to start the 12th section of the Residents Webinar Series. And before we do that, I would want to remind us of the webinar rules, which include that everyone should rename their devices for easy identification, rename your devices to your names, and then mute your mic to avoid background noises and to avoid distractions while the discussion is going on. And then finally, that all questions should be left to the end of the sections, where you can either put your question in the chat box or use your electronic hands, and we'll give you the floor to ask your questions. Okay, so we're about to, let me introduce the presenter, who is Dr. Anietie Etuk, from a registrar from University of Uyo Teaching Hospital, Akwa Ibom State. He will be taking us on a very important topic in anesthesia and also a very common exam question, which is arterial blood gases. And Dr. Etuk, you have 40 minutes to do your presentation. So let's all be quiet and listen to the presentation as we all learn together. Thank you very much. Dr. Etuk, you have the floor.
Good evening, professors here present. Good evening, consultants, senior registrars, and everyone else here present. My name is Dr. Etuk, and I'll be presenting topic arterial blood gases. I'll be going through the following outline. Introduction, I'll talk about clinical relevance, talk about some indications for arterial blood gas analysis, sample taking and analysis. I'll also define some terms and talk about the interpretation, and then I will summarize. As a way of introduction, blood gas analysis or arterial blood gases is a test which measures the pH, the partial pressures of carbon dioxide and oxygen, and also the bicarbonate concentration, among other parameters in arterial blood. It's essential for the diagnosis and management and managing the oxygenation status and acid-base balance of high-risk patients, especially critically ill patients and patients who are in the intensive care units. Arterial blood gases analysis evaluates how effectively the lungs are delivering oxygen to the blood and how efficiently carbon dioxide is being eliminated from the blood. The arterial acid-base disturbances are indicators of serious underlying pathology rather than being pathologies themselves. So arterial blood gases examination is a useful investigation in patients who are suspected to have respiratory or metabolic disease, and serious blood gas investigations can monitor the progress of treatment of any underlying disease that is being targeted. The blood gas should be considered in conjunction with the patient's clinical condition. And however, there is a limitation to arterial blood gas in the fact that it measures the extracellular fluid and not the intracellular pH and gas tensions also. So with the advancement of technology, we've been able to miniaturize most of our arterial blood gas sampling devices. So below we can see pictures, or beside this, we can see two pictures of different types of machines that could be used to measure arterial blood gases, together with the cartridges that could be used also. These machines usually require regular servicing and calibration by qualified technicians. Most machines may be able to perform automatic calibration depending on the number of cycles they perform or by time. Most cartridges that are available can take up to 150 to 200 samples. What is the importance of arterial blood gas? So, what are the importance of arterial blood gas? The utilization of an arterial blood gas analysis has the following advantages. It aids in establishing diagnosis of critically ill patients. It aids in monitoring and also guides treatment plan for patients. It aids in the ventilatory management of patients. It also improves management of the acid-base balance of patients who are critically ill or who are on some particular medications. It helps to optimize their treatment. We also use arterial blood gases to identify pathologies in the electrolyte dyselectrolytemia, and this may also help in patient management. Indications: identification of respiratory and metabolic or mixed acid-base disorders with or without physiological compensation by means of estimation of the pH, that is hydrogen ion concentration, the carbon dioxide levels, and also the partial pressure of carbon dioxide. Measurement of partial pressures of respiratory gases involved in oxygenation and ventilation. Monitoring of acid-base status in patients who have conditions such as diabetic ketoacidosis, who are on insulin infusion, or who are on active management for diabetic ketoacidosis. Arterial blood gas and venous blood gas sampling could be done simultaneously for comparison. Also, subsequent monitoring of patients who are being managed for diabetic ketoacidosis. Assessment of the response of therapeutic interventions such as mechanical ventilation in patients with respiratory failure. It could also be used to determine the need for home oxygenation in patients who have had advanced chronic pulmonary disease. It could also be used in quantification of oxyhemoglobin, methemoglobin, and carboxyhemoglobin. It could also be used in estimation of electrolytes, as earlier mentioned. So sampling techniques. A sample can be obtained either by withdrawing blood from an indwelling arterial line or from arterial puncture with a needle and a syringe. So the common sites for sampling include the radial artery, the brachial artery, the femoral artery, and the dorsalis pedis artery. Most commonly used is the radial artery and the femoral artery. Usually we want a small to use a small diameter needle, either a 22 or a 23 gauge needle, so that we can minimize trauma and also minimize the risk of vasospasm. The syringe should contain heparin. Usually there are some syringes that come pre-heparinized. However, if you do not have a pre-heparinized syringe, you could also infuse heparin into a syringe just to flush the barrel wall of the syringe and then expel the air, so that the heparin only fills the dead space of the syringe. So this is just a pictorial representation of a pre-heparinized syringe for arterial blood gas sampling. So the equipment we'll require for this procedure will include a clean tray. We also need sterile gloves. We also need an antiseptic solution. Recommended is the chlorhexidine gel. However, you could also use iodine solutions such as povidone iodine. A local anesthetic agent would also be required to minimize the risk of pain, or to minimize pain. Also, you will need heparin and the pre-heparinized or a normal syringe of small diameter. A paper bag will also be needed, and an ice pack also. Preparation of patient for sampling. It's important to record the patient's temperature prior to the procedure being performed. It's also important to record the patient's inspired oxygen concentration. Especially important if the patient is on mechanical ventilation. It's also important to heparinize the syringe to prevent blood clotting as already described. Allay anxiety of the client because most patients who are conscious coming for arterial blood sampling may have anxiety. So it's important to counsel your patient adequately, obtain informed consent, and allay any anxiety. An Allen's test should also be performed prior to sampling. So what is an Allen's test? An Allen's test just basically describes what we want to do to ensure that there's adequate blood circulation in the hand where we want to sample. Remember, we said that the most common artery used is the radial artery. So in an Allen's test, we want to occlude the radial and ulnar artery simultaneously. Before this, we want the patient to elevate the hand to either 30 degrees or 45 degrees. We also want the patient to clench the fist on that hand very tightly, and then want to occlude the ulnar and radial artery. After occluding the ulnar and radial artery, we release the pressure on the ulnar artery and watch for blanching, or rather watch for return of rubor to that hand in the area being supplied by the ulnar artery. Then we can now do the same for the radial artery. This ensures that there's efficient collateral circulation, because we are going to puncture this artery and we don't want a situation where patient has complications from this procedure. So as already described, patient clenches the fist, firm pressure is applied to the radial and ulnar artery. Patient then relaxes the hand and release the pressure on the compress of the radial artery and then the ulnar artery. We expect that the palm should flush within 5 to 15 seconds. So in the sample collection, a sample can be collected either by withdrawing blood from an indwelling arterial line or by arterial puncture. We want to wash our hands properly, we want to wear sterile gloves, we want to place the patient's hand just below the wrist on a firm surface so as to elevate the hand at the area of the wrist. What we want to achieve there is that the radial artery comes a little bit towards the surface and aids in the arterial, in the sampling of the arterial of the radial artery on that hand. So we'll ask the patient to clench the fist and then unclench the fist after blanching, and until blanching of the skin occurs. Then we release the pressure on the ulnar artery by removing the thumb on it, watch for return of circulation. Then after that, we palpate the radial artery for pulsation. We want to puncture at 45 to 60 degrees, at the angle of 45 to 60 degrees. Arterial blood usually rushes with great force, so you watch for that. There should also be bubbling. That's how you know that we are in an artery. We want to redraw 2 to 3 mL of blood for sampling. Post-puncture, we want to remove any air bubbles from the syringe and cap the syringe properly. We want to further dispose the needle into a shaft container, roll the syringe to mix the heparin with the sample, and then immerse the sample in an ice, in a container with the ice pack. This is usually done if we expect that we will spend more than 15 minutes before analysis of this sample. However, in most centers, we also want to ensure that we do this in case there are any delays. We want to maintain firm pressure on the puncture site for about 5 minutes, and then send the sample rather to the lab. If prior to sending the sample to the lab, we want to indicate the date and time of collection of the arterial sample. We want to indicate the fraction of inspired oxygen of that patient. Also want to indicate patient's temperature. If patient is on a mechanical ventilator, you want to indicate the ventilatory parameters also. So this is just a arterial evidence of what arterial blood sampling from the radial artery would look like. You can notice the firm board just under the patient's arm, angulating the arm upwards. Then you can also notice the bright red coloration of the blood in the syringe. Okay, what are the complications that could arise from arterial sampling of an artery? There could be bleeding, there could be infection at the puncture site, there could also be hematoma under the skin, there could also be pain, thrombus formation in the artery, there could be a feeling of lightheadedness, usually due to vasovagal response. There could be numbness in that hand. What are the contraindications to arterial blood sampling? If there's an overlying infection or burns at the site where you want to sample, please do not take that sample. If if there's absent collateral circulation as evidence from the Allen's test, you also do not want to take that sample. If there is intravenous shunting of the artery, usually seen in the radial and brachial artery, if there's severe atherosclerosis, if patient has Raynaud's disease, or if there's coagulopathy in such patient, you want to suspend this arterial blood sampling. What are the parameters that we could get from arterial blood sampling? There are some parameters that are directly measured and can be gotten from the machine analysis. There are some parameters, however, that we need to calculate. So the parameters that could be directly measured include the partial pressure, the partial pressure of oxygen in the arteries, the arterial partial pressure of the partial pressure of carbon dioxide, also the pH. Some electrolytes could be measured, such as sodium, potassium, calcium, and chloride also could be measured. Lactates, glucose, and hemoglobin also could be measured. We'll, however, need to calculate the bicarbonate concentration. We'll have to calculate the base deficit. We also have to calculate the oxygen tension in the artery. We also have to calculate the standardized bicarbonate concentration also. The hematocrit of the patient can also be calculated from the parameters which have been measured. Okay, so just by the side of this, we can see what the result of an arterial blood gas analysis would look like to the far right. I will define some terms briefly. Let's talk about the partial pressure of oxygen in the artery, the arterial partial pressure of oxygen. So it's of vital importance because it is used in determining a patient's acid-base status, and normally low readings would indicate hypoxemia. The normal range should be between 80 to 100 millimeters of mercury, or 10.6 to 13.1 kilopascal. So if you're measuring in millimeters of mercury, you can divide by a factor of 7.5 to get it to kilopascals. This is when this normal range of arterial partial pressure of oxygen is in room air where FiO2 is 21%. In general, it's an indicator of the severity of lung disease, but it cannot be interpreted without knowing the FiO2. The worse the lung disease, the lower you expect that the partial pressure of oxygen in the artery should be with any given FiO2. A rough approximation of the predicted partial pressure of oxygen can be gotten by multiplying the partial pressure of oxygen by 3 to 5. So usually an average of 4 is used, and you multiply this by the partial pressure of oxygen. So let's assume that patient is currently breathing 40% oxygen. So we expect that patient should have a partial pressure of oxygen of 120 millimeters of mercury. Moving forward, we want to talk about the oxygen tension in the artery. Oxygen saturation measures how much of the hemoglobin in red blood cells is carrying oxygen, is able to carry oxygen. Although it is similar to the SpO2, it is usually more accurate. Normal values are above 95%, although levels above 90% is usually acceptable in critically ill patients. So we just have an oxygen dissociation curve here, which shows us it's a sigmoid curve that shows us how much oxygen is being carried by the blood. We have factors that affect the oxygen dissociation curve, shifting it either to the right or to the left. Factors such as decreased temperature, decreased 2,3 diphosphate, and then decreased hydrogen ion concentration. Factors that will shift the oxygen dissociation curve, this is just by the way, to the right, will include increased temperature, increased hydrogen ion concentration also. Let us define pH. pH talks about the total acidity or alkalinity of the sample. It indicates if the patient has acidemia or alkalemia. The pH measures the hydrogen ion concentration in the blood. The normal pH of blood should be between 7.35 to 7.45. There's usually no unit that is attached to pH. A medium with a pH less than 7.0 is called acidic, and a medium with pH greater than 7.0 is alkaline. So blood is basically basic. The partial pressure of carbon 4 oxide. This is The partial pressure of carbon dioxide dissolved within the arterial blood is used to assess the effectiveness of ventilation. A high PaCO2 will represent respiratory acidosis and indicate under ventilation. A low PaCO2 will represent respiratory alkalosis and may indicate hyper or over ventilation. The normal range for PaCO2 for a healthy patient is 35 to 45 millimeters of mercury or 4.6 to 6.0 kilopascals. Bicarbonate concentration. Why is bicarbonate important to us? It is important because it is a chemical buffer and one of the most important chemical buffers in the body. It keeps the pH of blood from becoming too acidic or too basic and indicates whether there is a metabolic problem present. Also, a low bicarbonate ion concentration will indicate metabolic acidosis, while a high bicarbonate ion concentration will indicate metabolic alkalosis. The normal range should be between 22 to 26 millimoles per liter. Standard bicarbonate is a useful term, which is more useful than the actual bicarbonate, and it has been corrected for abnormal partial pressure of carbon dioxide and also temperature. There's also a concept of base deficit. The base deficit is used to assess the metabolic components of acid-base disorders and indicates whether the patient has metabolic acidosis or alkalosis. A negative base deficit indicates that the patient has metabolic acidosis, while a positive base deficit indicates that the patient has metabolic alkalosis. The normal range is between minus 2.0 to plus 2.0, although some authors have described minus 2.5 to plus 2.5 millimoles per liter. So once again, this is just a summary of the value of the normal values that can be gotten from arterial blood sampling. pH should be between 7.35 to 7.45. Partial pressure of carbon dioxide should be between 35 to 45 millimeters of mercury. Partial pressure of oxygen should be between 80 to 100 millimeters of mercury. Bicarbonate ion concentration should be between 22 to 26 millimoles per liter. And an SpO2 should be between 95 to 100%. Remember, we are, of course, we're talking about arterial blood sampling. Acid-base balance. The main or primary aim of keeping this delicate balance is to preserve hemostasis. The hemostasis is a complex interaction that maintains all body systems to function within normal range. So an extreme change in this balance, such as a pH less than 6.8 or greater than 7.8, may result in disastrous changes such as denaturing of proteins or a shutdown of enzymatic and metabolic processes. Such environments would be incompatible with life. So types of acid-base imbalance. There could be respiratory acidosis, there could be respiratory alkalosis, there could be metabolic acidosis, there could be metabolic alkalosis also. There are also some mixed acid-base imbalance. So a simple mnemonic to remember acid-base imbalance is ROM. RO stands for respiratory opposite. This means that the pH, if the problem is a respiratory is a primary respiratory problem, then the pH and the partial pressure of carbon dioxide will be going in opposite directions. If the problem is a metabolic problem, then you expect that the pH and the bicarbonates this time will be going in the same direction. So ROM, respiratory is opposite, metabolic is equal. Let's talk about respiratory acidosis. It is defined as a pH less than 7.35 with a partial pressure of carbon dioxide greater than 45 millimeters of mercury. Acidosis is the accumulation of carbon dioxide, which combines with water in the body to produce carbonic acid, thus lowering the pH of the blood. Bicarbonate is usually normal. What are the causes of respiratory acidosis? Central causes, chest wall causes, they could also be neuromuscular causes, and intrinsic lung diseases. So the problems from the central point will include traumatic brain injury, if there's been a drug overdose, such as following use of drugs like opioids. If patient is obese, if there's also infection, such as encephalitis, then there could be a central drive depression. If the patient has chest wall injuries, if patient has just had a thoracic surgery, patients who have spine abnormalities such as kyphoscoliosis, patients with airway obstruction from epiglottitis or a tumor would also have could also have respiratory acidosis. Patients with neuromuscular diseases such as polio, patients with Guillain-Barré, patients with myasthenia gravis, electrolyte abnormalities such as hypokalemia, hyperkalemia. If there's also hypermagnesemia or hypomagnesemia, then there could be respiratory acidosis. Polio is of very, very serious import to us because it was from the outbreak of polio in about 1846, I think in Copenhagen, that we started that the evolution of acid-base imbalance diagnosis and treatment started in essence. We could also look up the history where we remember that about 1,500 medical personnel and medical students provided manual ventilation for more than 3,000 patients for about 156,000 hours. If there is intrinsic lung disease, patients could have respiratory acidosis. Causes of intrinsic lung disease such as COPD, that's chronic obstructive pulmonary disease, pneumonia, pulmonary edema, or lung fibrosis could predispose patients to having respiratory acidosis. Respiratory alkalosis, it is defined as a pH greater than 7.5 with a partial pressure of oxygen less than 35 millimeters of mercury. Alkalosis is due to excessive washout of CO2, usually due to hyperventilation, thus increasing the pH of the blood. The bicarbonate is usually normal. Causes of respiratory alkalosis would include CNS stimulation, such as in flight or fight mode, such as fever, such as fear, if patient is anxious. If patient is in pain, it could also be hyperventilation predisposing patient to respiratory alkalosis. If there is cerebral edema, or there is conditions of brain trauma, brain tumor, or a CNS infection, this could predispose patient to having respiratory alkalosis. Hypoxemia or hypoxia, if there is a lung disease, a long-standing or a chronic lung disease rather, if there is profound anemia, reducing blood supply. Also, if there is a low FiO2, Dilation of chest receptors in cases such as pulmonary edema, pulmonary effusion, pneumonia, pneumothorax, pulmonary embolism, also predispose patient to respiratory alkalosis. Use of some drugs of hormones such as salicylates, catecholamines, medroxyprogesterone, and progestins could predispose patient to having respiratory alkalosis. Pregnancy, liver disease, sepsis, and hyperthyroidism would also predispose patients to having respiratory alkalosis. Hello, please, am I still being heard now? Am I being heard now?
Yes, we can hear you. Please go ahead. Sorry, that was a mistake.
We'll talk about metabolic acidosis briefly. It is defined as a pH less than 7.35 with a bicarbonate less than 22 millimoles per liter. Loss of bicarbonate or addition of acid will cause metabolic acidosis. The partial pressure of CO2 is usually normal in this case. Any condition that will lead to tissue hypoperfusion or would also lead eventually to increase in lactic acid production, which will result in metabolic acidosis. So below you can see a picture of medications, alcohol, cigarettes, illicit or rather controlled substances also. So in talking about metabolic acidosis, we must not fail to mention anion gap. Anion gap is used to assess acid-base status in metabolic acidosis. It's based on the principle of electroneutrality. That is, the body is kept in an electroneutral state. So it is usually gotten by measuring the total anions and the total cations and subtracting it. The normal value should be between 8 to 6 millimoles per liter. However, during the course of this presentation, I saw that some authors have described 7 to 14 millimoles per liter also. Causes of metabolic acidosis will include metabolic acidosis could either be a elevated, that is high anion gap metabolic acidosis, or a normal anion gap metabolic acidosis. So causes of high anion gap metabolic Causes of elevated anion gap metabolic acidosis, we have a mnemonic that we usually use is the MOD-PILES mnemonic. So M is methanol intoxication, U is uremia, D is diabetic ketoacidosis. It could also be alcoholic ketoacidosis or starvation, causing high anion gap. Paraldehyde toxicity, isoniazide use, lactic acidosis, ethanol or ethylene glycol intoxication, and salicylates intoxication also will cause high anion gap metabolic acidosis. Normal anion gap metabolic acidosis, there is usually hyperchlorinemia. This could be due to GI losses of bicarbonate in cases such as diarrhea, if patient has an ileostomy, if patient has had a proximal colostomy, or if there's a urethral diversion. In the renal system, if there's excessive loss of bicarbonate as a result of proximal renal tubular acidosis, or if there is use of carbonic anhydrase inhibitor such as acetazolamide, this could cause a normal anion gap metabolic acidosis. Renal tubular disease such as acute tubular necrosis, chronic renal disease, distal renal tubular acidosis, aldosterone inhibitors, or normal saline infusion, or if patient is having total parenteral nutrition in the ICU, or if there's administration of ammonium in any form, this could predispose patient to having normal anion gap metabolic acidosis. On to metabolic alkalosis. It is defined as a pH greater than 7.5 with a bicarbonate greater than 28 millimoles per liter. It is due to excessive acid loss, such as in cases such as repeated vomiting or nasogastric suctioning, or if there's bicarbonate retention in overuse of sodium bicarbonate. The partial pressure of carbon dioxide is usually normal. Causes of metabolic alkalosis will include alcohol abuse, hyperaldosteronism, diarrhea or vomiting, if there is high fever, that's high-grade fever, if patient is on diuretics, or if there's cystic fibrosis in such patients. So we'll just briefly summarize some selected mixed and complex acid-base disturbances. Respiratory acidosis with metabolic acidosis. So patient could be having respiratory acidosis and metabolic acidosis at the same time. What will we see on arterial blood gas sample analysis? We'll see a reduced pH, there'll be a reduced bicarbonate and an increased partial pressure of carbon dioxide. If patient could also have respiratory alkalosis with metabolic alkalosis. So in this case, there will be increased pH, there will be increase in the pH, there will also be increase in the bicarbonate ion concentration, but there will be a reduction in the partial pressure of carbon dioxide. If patient is having respiratory acidosis with metabolic alkalosis, then patient may have a normal pH, but there will be an increase in partial pressure of carbon dioxide and an increase in the bicarbonate. Patient could also be having a respiratory alkalosis with metabolic acidosis. In this case, the pH may also be normal, but there may be reduced partial pressure of carbon dioxide and reduced bicarbonate. Patient could also come in with metabolic, or patient could present rather with metabolic acidosis and alkalosis. And in this case, pH is usually normal and bicarbonate is usually normal. However, patients may have uremia or ketoacidosis with vomiting, or they may have been repeated NG tube suctioning or use of diuretics in such patients. Please excuse me 1 minute. Okay, parameters are measured in the arterial blood gas analysis, like already described, all what we've just talked about: partial pressure of oxygen, partial pressure of carbon dioxide, the pH of arterial, the pH of arterial blood, electrolytes could be analyzed: sodium, potassium, calcium, which is corrected, and then chloride also. Lactate could be analyzed, and glucose also could be analyzed. The hematocrit, rather the HB of the patient, that is the hemoglobin concentration, could be analyzed. The calculated the parameters that will be calculated will include bicarbonate, the best excess, the alveolar oxygen content, the peripheral oxygen tension, and then the hematocrit of the patient. Factors that will affect ABG reading: temperature. The machine usually analyzes blood at 37 degrees Celsius. So if patient is hyperthermic, then the measured oxygen the measured partial pressure of oxygen and carbon dioxide will be less than what the patient actually has. If patient is hypothermic, then the measured partial pressure of oxygen and carbon dioxide will be more than what the patient actually has. So it said that for each degree Celsius rise in temperature above 37.0 degrees Celsius, then the partial pressure of oxygen will rise by 5 millimeters of mercury. And for each degree Celsius rise above 37 degrees Celsius, then the partial pressure of carbon dioxide will rise by 2 millimeters of mercury. The FiO2 of the patient can be gotten the partial pressure of oxygen of the patient can be gotten from the FiO2 that the patient is currently having. For a patient who is respiring at room air, is respiring in room air at 21% FiO2, then the fraction of inspired oxygen we expect it to be between 63 rather to about 85 millimeters of mercury. Steps in evaluating arterial blood gas. In evaluating the arterial blood gas results, we want to identify the demographics and ventilatory settings. We also want to examine the oxygenation, examine the pH, examine ventilation, that's partial pressure of carbon dioxide, examine the metabolic components represented by the bicarbonate concentration. Then want to determine the source of the disturbance, determine the compensation, then put it all up together, and then look at the electrolytes, glucose, and then the hemoglobin of the patient. So interpretation of the result, they could be hypoxia if the partial pressure of oxygen is less than 60 millimeters of mercury. There could be acidemia if pH is less than 7.35. There could be alkalemia if pH is less than 7.45. In practice, acidemia and alkalemia are referred to as acidosis and alkalosis. So in acidosis, like we've already mentioned, it could be respiratory or metabolic. Alkalosis also could be respiratory or...
Sorry, you have 5 minutes to go. 5 minutes more.
Thank you, Ma. The body could also be attempting to compensate for this abnormality. This compensation could be seen. Respiratory compensation is usually quick. Metabolic compensation is usually via the kidney, so it usually takes hours to days. Patient never usually really overcompensates, and compensation is usually never really complete. So this table just says what I have just spoken about. There's a Winter's formula. Winter's formula is used to evaluate the respiratory compensation when metabolic acidosis is present in a patient. This is used to give an expected value for the patient's partial pressure of carbon dioxide, which helps to assess whether or not the patient is adequately compensating for the acidosis. So the Winter's formula is that the partial pressure of carbon dioxide is equal to the bicarbonate concentration times 1.5 plus 8 plus or minus 2. So interpretation of an ABG result, we just look at it together, look at the oxygenation of the patient. Is the partial pressure of oxygen consistent with the FiO2 of the patient from our formula that we've calculated? What do we expect it to be? Is the overall picture of the patient's acidemia or alkalemia, looking at the pH? Furthermore, is there acidosis? If there is acidemia rather, is the primary defect a metabolic defect, a respiratory defect, or is it mixed? We can see this by evaluating the partial pressure of carbon dioxide. Respiratory acidosis, there will be high carbon dioxide tension. In metabolic acidosis, bicarbonate will be low, or the base excess will be negative. If there is both of these conditions, then there is a mixed metabolic and respiratory acidosis. If there is respiratory acidosis, is there metabolic compensation for this respiratory acidosis? This will be seen if the partial pressure of carbon dioxide is high, but the metabolic component is going in the opposite direction as earlier stated. And then is there metabolic compensation? Moving forward, if there's metabolic acidosis, is there respiratory compensation? The base negative will be negative. The base excess rather will be negative if there's respiratory compensation, that there's metabolic acidosis, but the respiratory component is going in the opposite direction. then we can now suspect that there's respiratory compensation. If there is alkalemia in the patient, we want to go ahead to look, is the primary problem a respiratory problem or a metabolic problem? How would we know? The primary defect will go in the same direction as the pH. So remember that respiratory goes opposite and metabolic goes equal. If metabolic acidosis or metabolic or respiratory alkalosis is present, is there any compensation of any of the of any of them? You use the same principle as above. Then you summarize everything we've gotten. Is there metabolic acidosis, respiratory acidosis, metabolic alkalosis, or respiratory alkalosis, or is it a mixed condition? And then furthermore, we want to go ahead to establish the cause of this. Remember, we said that acid-base imbalance is a symptom, not the primary cause. So the relationship between this, already spoken about this, we just like to take one or two scenarios because of time. So we'll just take two scenarios. Let's take a scenario, a patient who is being on morphine infusion over the last 48 hours after a total abdominal hysterectomy is very comfortable and responds to command appropriately. The recovery ward house officer on his rounds performs a blood gas check and checks the patient, and the below result is found. The partial pressure of oxygen is 50 millimeters of mercury. You can see that that is a bit low. You can see that the peripheral oxygen saturation is a bit low also. You can see that the partial pressure of carbon dioxide is 57.3 millimeters of mercury. This is a bit on the high side. There is also acidemia in this patient, evidenced by pH of 7.41. There's also a marked rise in the bicarbonate ion concentration. This result has already calculated the best excess for us and has given us the potassium level of the patient. So from this result, we can say that this patient has a fully compensated respiratory acidosis. Let's see a patient who has had metabolic acidosis with compensatory respiratory alkalosis. The FiO2 that the patient is respiring on is 21%. That means patient is in room air. The partial pressure of oxygen is 80 millimeters of mercury, which is about normal, is what we expect. The partial pressure of carbon dioxide is 26 millimeters of mercury. 26 millimeters of mercury for partial pressure of carbon dioxide is a bit low. The bicarbonate ion concentration is also low. Base deficit is low. So we say that this patient has metabolic acidosis. So we say that this patient has metabolic acidosis. So briefly, we have a diagram here, an algorithm rather, that shows us a summarized version of ABG interpretation where patient has acidosis. And also for alkalosis, we have another algorithm here that can be used to make diagnosis from arterial blood gas sampling. In conclusion, acid-base disturbances are indicators of serious underlying pathology rather than being the pathology themselves. Serial blood gas investigations aids in monitoring the progress of treatment or monitoring treatment of underlying diseases. It does have a limitation in the fact that it measures the extracellular fluid, and we do not really get to see what is happening inside the cells. The blood gas should be considered in conjunction with the patient's clinical condition so as to make appropriate diagnosis rather. These are my references. Thank you.
All right, thank you very much, Dr. Etuk, for that detailed presentation. We appreciate all your efforts in making this presentation a success and a reality today. So thank you very much. So now it is time for question and answer. Before we go to the chat box, does anyone have any question or comment to make? You can unmute yourself and you have the floor. Thank you. Any question from anybody before we go to the chat box? Okay, so while we are waiting, let's go to the chat box and see some of the questions that have been asked. The first question I have here says, how will you compare arterial blood gas and venous blood gas? That's the first question. You can go ahead, Dr. Etu.
Okay, ma. How will we compare arterial blood gas and venous blood gas? Venous blood gases will provide a lower partial pressure of oxygen. There will be a higher partial pressure of carbon dioxide. Remember that the major gas in the veins is carbon dioxide. Arteries carry blood, artery carry oxygenated blood, veins carry deoxygenated blood. So partial pressure of oxygen will be lower compared to that of arterial blood gas analysis. That in arterial blood gas analysis, partial pressure of carbon dioxide will be higher compared to that in arterial blood gas analysis. And there will be a slightly lower pH than that done in ABGs due to oxygen consumption from the cell. Remember that the venous blood is coming post metabolism. So the pH will be a bit low. I hope I've been able to answer that question.
Okay, so that was a good attempt. The second question here says, if there is absence of hello. So the second question says, if there is absence of collateral circulation, will Allen's test be positive or negative?
Thank you, Ma. This question, sorry, I'm just going through the chat box and I've seen that General Gumbi is around. Good evening, sir. Welcome to the presentation. So he had answered the question. And if my prof has answered the question, who am I to go ahead? So I'll just read out his answer. A positive Allen's test indicates good collateral circulation, while a negative Allen's test reveals a poor or absent collateral circulation. So in light of the above, if there's absence of collateral circulation, the Allen's test is negative. It will be very dangerous to go ahead with sampling of arterial blood gas from the radial artery in this case. So you want to avoid this. Thank you.
Well done,
Okay,
doctor. Thank you.
very much.
Thank you, sir.
Thank you, General. We appreciate the answer. Thank you very much.
You're welcome.
All right. The third question said, could you briefly explain modified Allen's test and where is it applicable? Hello, can you hear me, Dr. Etu?
Yes, ma. I'm with you, ma. Sorry, a little bit network glitch there. So,
Okay.
modified Allen's test. I have seen conflicting ideas. I've seen conflicting information when I was preparing for this presentation. One information says in modified Allen's test, in modified Allen's test, the ulnar and radial artery are occluded at the same time after telling the patient to clench the fist. After telling the patient to clench the fist rather and elevate the hand. And then the ulnar artery the pressure on the ulnar artery is released, and watch for return of for rubor on the area being supplied by the ulnar artery, and then we release the radial artery also, the pressure on the radial artery, and then we watch for that. However, I also saw where it was described that an X-match bandage was used to occlude around the forearm, to occlude circulation around the forearm, and then this test was carried out. As to where this last one I'm just talking about now, it was further stated that a modified Allen's test is useful where the patient is unconscious or unable to obey command. So this is where modified Allen's test can be applicable, where patient is unconscious or where patient cannot obey command.
Okay. Thank you for that response to that question. I think you did well on that. Let's quickly go to the next question. And someone said, is sodium bicarbonate therapy beneficial in management of high anion gap metabolic acidosis? Is it beneficial? The use of sodium bicarbonate, is it beneficial in management of high anion gap metabolic acidosis? That's the question.
For management of
Hello, are you with us? Dr. Etuk.
Sorry, I was muted. In
Okay.
in metabolic acidosis, in the management of metabolic acidosis, you want to measure how much you want to get a picture of the arterial blood gases. Then you want to treat according to the level of severity of the disease. So this means that if you have a very severe metabolic acidosis where pH is about 7.2 or 7.1, please go ahead and use sodium bicarbonate. How do we use sodium bicarbonate? You calculate using the formula, and then you give half of it immediately and give the remaining half over the next 24 hours, over the remainder of the 24 hours. So if the metabolic acidosis is not corrected, you want to institute more how do I say this now? You want to be more aggressive with the correction. Hemodialysis is usually the way to go. So yes, sodium bicarbonate can be used in the management of high anion gap metabolic acidosis.
Okay, thank you very much. We have someone raising her electronic hands up. Dr. Ngozi, you can go ahead, unmute yourself and ask your questions. Thank you very much.
Okay, good evening, seniors and colleagues in the house. Thank you, Dr. Etu, for the presentation. My name is Dr. Anozie Ngozi. So I was wondering, when you're talking about the contraindications for the for performing the arterial blood gas using the Allen's test, modified Allen's test, then when you were done, you said if you have any of these contraindications, you may consider not carrying out the procedure. And I was wondering, is there anything stopping you from getting the arterial gas from another source, like the femoral artery?
Hello, Dr. Etu. Hello. I think we've lost him. Oh, that might just be an omission, but let's wait for him to join.
Okay.
Of course, if there is contraindication, you can always go to the femoral artery and take your samples. Dr. Etu, did you hear her? Did you get a question?
Okay, thank you. Yes, Chief, I heard her. Thank you, Chief, for the input. Yes, I think, sorry, that might have been a slip of tongue. There are some contraindications that we can work around. For example, infection bonds around the site where you want to take the arterial blood sample from. If it's at the radial position, you want to use another artery. That's why we have other options. You could use the femoral, you could use brachial artery, you could also use dorsalis pedis artery. However, I think what you meant is that if we have a patient with coagulopathy, okay, what I meant was that if a patient with coagulopathy, it would be unwise to go ahead and stick in a needle, especially if it is if the coagulopathy has been established. It may be very, very, very unwise to go ahead and stick in a needle. So that may be an absolute contraindication.
Okay. Sorry, let's go over to the next question because of want of time. The next question says, what's the difference between acalemia and acalosis? What is the difference between acalemia and acalosis?
Okay, alkalemia, an arterial blood gas analysis, you see a pH of 7.5. That is relative alkalemia. Normal pH of blood should be 7.4. So you start seeing a pH of 7.5, that is alkalemia. However, this is usually referred to as alkalosis in the sense that working alone with the pH may not be very efficient in making it may not be very efficient in making a diagnosis, working alone with just the pH. So alkalemia and alkalosis are basically the same thing.
Okay, thank you for that response. The next question says, could diarrhea be a cause of metabolic alkalosis? Can diarrhea cause metabolic alkalosis? Hello, are you there?
Sorry, I keep forgetting to unmute myself. Maybe I shouldn't even mute it at all.
Leave yourself unmuted now, for now.
Okay.
You can leave yourself unmuted.
Alkalosis. So in alkalosis, there's loss of electrolytes. And alkalosis may cause metabolic acidosis. Diarrhea, yes, diarrhea rather may cause metabolic alkalosis because there's loss of electrolytes, particularly chloride and potassium. So there may be volume contraction, which will eventually lead to metabolic alkalosis. So yes, it could cause this.
And I think so too. Sorry, let's recognize the presence of one of our great mummies in anesthesia, Professor Elizabeth Nwaso. Sorry, I'm just seeing your electronic and you can go ahead, ma. Thank you very much for joining us today. Thank you. Prof, ma, good evening, ma.
Okay, good evening. Good evening, everybody. Thank you for a brilliant presentation. I just wanted to congratulate the presenters and the moderator, the presenter and the moderator and the organizers for the excellent job. I think it's a very good topic. It's very apt. And especially as exams are around the corner, this is an all-time favorite during the exams. And also in our clinical practice, the knowledge of this topic is very necessary in our day-to-day work as anesthetists and also in the intensive care unit. So I just call on everybody to pay good attention and to take all the messages, take home messages and study the topic and know it very well at the tip of our hands. Yeah, so what I want to say is I just wanted to ask us to be aware that we can actually use venous blood gases estimation, and it correlates well with arterial blood gases. In fact, in my recent practice, I've in like so many years now, we've not had to do ABGs. We've not had to do arterial blood gases for a long time. So what we just do is venous blood gas estimation. So just to tell us that we should know that clinically it can correlate very well and it's equally useful in patient care and clinical practice. Thank you.
Thank you very much, Prof. Ma. Thank you for that important contribution. We appreciate you and we appreciate your presence in our today's webinar. Thank you so much, ma. Thank you so much.
Yeah, welcome.
Thank you. Okay, so the next question says, from the presentation, salicylate causes both metabolic acidosis and respiratory alkalosis. Is that correct? Dr. Etuk, are you still here with us? Hello?
I think he has
Hello,
been logged
Dr.
out.
Etuk.
I think network
Okay.
has logged him out. You'll probably join back soon.
Okay, that should be a network issue, but I don't think so. Would that be a typo error? Okay, should we give him some minutes to join? Let's give him few seconds to join back.
Okay, but somebody else,
Meanwhile,
anybody
what
can discuss the
uh,
question.
it's not
Anybody
really
else can
it's
respond.
just a clarification. Okay, Prof Ma.
What
Someone,
I'm
I think it's
saying is
from his
that
slide.
anybody else can respond.
Okay, okay. Okay, meanwhile, while we are waiting for him, let's just read up. There are some chats in the chat box. Someone said, well done, Doc. Modified Allen's test is performed using Dorsales pedis artery. That's true. For high anion gap, metabolic acidosis address the primary pathology. Why sodium bicarbonate therapy is not beneficial. Okay, this is just a contribution from one of us. Thank you very much for that contribution. This next question says, what does CAH in clinical scenario 7 mean? I think it's from his slides. Could that be total abdominal hysterectomy? Dr. Etuk, are you back?
Yes, ma'am, back, ma'am.
Okay, somebody was saying that in your slide, from the presentation you just made, that you said that salicylates and causes both metabolic acidosis and respiratory alkalosis. Is that correct? From the slide you shared while doing the presentation. Hello, did you hear me?
Yes, ma'am. Are you hearing me?
Yes, I can hear you now.
Okay, so salicylates will inhibit citric acid cycle. This will cause increased oxygen consumption. So yes, it could actually cause either of the two.
Okay. All right, thank you very much. So I've read, somebody made a comment, a contribution, which I've read out. So the next question says, what does TAH in clinical scenario 7 mean? What does TAH? I think
Abdominal
that's, yes.
hysterectomy.
Okay, so the person
Abdominal
just wanted,
hysterectomy.
all right, thank you very much. The person just wanted to know. So the salicylate poisoning causes high anion gap and high osmolar gap metabolic acidosis. It also causes hyperventilation. Thank you for that contribution. The next person says, please, what is the difference between oxygen saturation and SpO2?
Oxygen saturation, I think you mean SaO2
Partial.
and SpO2. So SaO2 is the arterial arterial oxygen tension or arterial oxygen saturation. Is a more reliable indication of how much oxygen is in the body. That is how much of the ventilatory status of that patient. A lot of factors can affect or influence SpO2. We'll not go into that now. And also remember that SpO2 below 80%, right, is unreliable. So yes, these are differences and come out with at this point.
Okay, thank you very much. I think Dr. Liu, okay, he reacted to that question, and we are saying the same thing, that it can cause both metabolic acidosis and respiratory alkalosis. That's salicylates. Salicylate poison causes mixed acid-base disorder. All right, thank you very much. There are no other questions in the chat box. So at this point, we want to invite any of our trainers, professors, consultants that have any comments on this topic. You have the floor. Any of our consultants, professors that are present in this meeting, you have the floor if you have any comments to make. Thank you very much. Okay, if there is none, At this juncture, we have come to the end of today's webinar series, residence webinar series, and then I would want to hand over to the NSA schools who are present in this meeting. I don't know if Dr. Kalu Quinet is present in this meeting, or our NSA President, Professor Dati. Prof, are you here? Okay. Hello, Dr. Kalu Quinet. Ma, are you here? I don't seem to see any of our NSA schools here. Okay.
Hello, Dr. Ezewa Balik. Ezewa
Yes, Prof. Ezenwa Bachili. Yes, Prof.
Ezewa Balik. I'm not Prof. I'm Dr. Daramola. I'm the consultant
Okay, sorry,
administrator.
I thought it was Professor Wanso that was talking.
No, since you were asking, and I scrolled through the platform, I can't see Prof. I can't see the Vice President. And as the welfare officer, I think I'm the only
Okay.
NSA school president. So
Okay.
you want us to give the closing remark, right?
Yes, ma. Yes, ma.
All
Thank
right.
you very much.
Okay, so on behalf of the president, vice president, and the ESCO at large, I would like to appreciate the presenter of today and the moderator. You both did a great job. Thank you so much. I also like to thank our profs present. I think I saw the Professor Wanso. Thank you so much, Ma. I also saw Dr. Mafe, the coordinator of School of Anesthetic Study, Badagry, Lagos. Thank you. We appreciate our seniors. We appreciate you, ma'ams, for joining us, and other consultants here present. I might not be able to recognize and everyone. Thank you so much. Thank you, every resident that have joined. I want to believe we have picked one or two things. And like Professor Wanso said, this topic, it's is a choice topic for exams. And as the exams are around the corners, I will encourage us to please go back and read it, reflect on it, and digest it. There are exam questions, both oral, written, MCQs in all aspects of the exams. And I wish us all the best. Thank you so much, and good night, everyone. Thank you.
All right, thank you very much, ma. We appreciate your presence. Thank you, everyone. So at this point, we have come to the end of this webinar section, the 12th section of the residence webinar series. We want to thank everyone that made it to the discussion this evening. We'll meet again in 2 weeks' time. So bye, everybody. Have a nice evening. Thank you.
Bye. Thank you very much.
Thank you. Just to say that General Gumbi was around earlier, and Dr. Lateju, president of SOAN, is around.
Oh, wow. I didn't see Prof. I'm so sorry I omitted. General and Prof. Thank you, ma'am.
Well done, everyone.
Prof, thank you, President of SWAN. We appreciate you,
well
sir,
done.
for taking time to join us. God bless you, sir.
Okay, well done.
And thank you to General in absentia. Good night, sir. Good night, ma'am.
Well done, everybody. Good night. My president, good night.
Thank you, Prof. Good night, ma.
Good night.
Thank you, Dr. Etuk. We appreciate your lecture.
Thank you.
Well done, Dr. Etuk. That was a good one.
Thank you, ma.
Dr. Yewako, I see you.